cannulation, but not exactly the same as those two. So when we talk about this, what I want you guys to be able to do at the end of this is to think about why do you put kids on VA versus why do you put kids on VV, and what are the pros and cons of both of those. So in terms of VA and VV, really the goals are the same when you think about it, is that you're trying to provide good oxygenation to the body of your patient for the shortest time possible if you're using something outside of their own body. So it's like anything else that we do, right? That you're just trying to do the least for the least amount of time. In addition, because you are doing this for a patient providing oxygenation through ECMO, in my mind, the way I think about this is if you're taking on all the risks of the ECMO circuit, then you might as well try and minimize the risks that you have elsewhere. So that what that means is, can you dial back on the ventilator? Because what you've already said is your patient is failing on the ventilator, and that's why you're going on, if you're going on for respiratory reasons, or if you're going on for cardiac purposes, still you're getting the bonus of the ventilator and the ECMO circuit acting as your lung. So you shouldn't have to beat your lungs up as hard while you're on the ECMO circuit. Now, the whole idea of breast settings is a debatable thing. So what is VA ECMO? So we were just talking about this a minute ago in the cannulation talk. So VA ECMO is taking blue blood out of the body, sending it through an alternate heart is the way I think about it, which is your pump head, that's your cardiac output, as well as putting it through an alternate lung and acting as ventilation and oxygenation. So what do we get then? So you get full bypass of the lungs, everything comes out of the lungs, minimal is going through the lungs, and you get to bypass the heart. So these are the numbers that we were talking about this morning, that if you do a right-sided cannulation, you'll decompress the heart about 65 to 75% of the time. And it is kind of hard to remember that, because as soon as you start talking about full flows, people really do start conceptualizing that that means you're taking all full the amount of blood volume out of the body, but you're really not, as opposed to a left cannulation where you've got 75 to 90% that you're decompressing. The only variant on this, and I'll shadow it here and we'll talk about it again later, is the whole idea that we were talking about in cannulation, about if you have an ASD in place, then even without a left atrial vent, you may be doing a little bit more than the 65 to 75% decompression, because you'll be stealing from the left atrium in the right cannulation. So what are all the reasons for which someone gets cannulated to VA ECMO? So you can memorize all these individually if you want to, but what it really boils down to is what you guys can figure out on your own. If you're going to VA ECMO and you first break this down to just thinking about that you have a failure of cardiac output, how do you guys know when you're assessing your patients that you have inadequate cardiac output?
Sorry, what was your question again?
When you're assessing your patients at the bedside, how do you know that they have inadequate cardiac output?
Your urine output. Urine output.
Right. So you're looking for signs of end-organ perfusion, which may be urine output. What else? Hypertension. Lactate. Right. And your venous sat, but not, and I guess depending on where you are institutionally, people use more or less of the venous saturation. So a lot of these things just talk about that, right? Is that they're just different ways of saying that your patient is in the low cardiac output state. Now, if you have a patient that you're putting on VA ECMO because they have full pulmonary failure, what do you guess you look for? What do you look for before you intubate a patient who's in respiratory failure? Hypoxia, and occasionally hypercapnia, although hypercapnia is much less common of a reason why we cannulate patients to ECMO. It's almost always because of oxygenation, in part because patients tolerate low pHs if they have normal cardiac function so well, so that you can deal with the permissive hypercapnia. And then if your hypercapnia gets bad enough because of the gas laws, if your PaCO2 goes up that high, eventually your PaO2 drops, and so ultimately you still end up with hypoxia as the indication for going on ECMO. The only other one to me that falls in here just as an outlier is just thinking about pulmonary hypertension. But really your indications for going out for pulmonary hypertension are all the things you told me about already. Because if you have a patient who has the capacity to shunt, whether it's through PDA or an ASD, their pulmonary hypertension is that bad, they're gonna be quite severely hypoxic, so you're still going on for hypoxia. It's just not for primary parenchymal reasons that they're hypoxic. Or if they don't have a shunting defect, then they have that bad of pulmonary hypertension. They have overt signs of right-sided failure, and they have inadequate left-sided filling. And so then they have inadequate systemic cardiac output. So all the indicators you just talked about are still in place. So what are the advantages of VA ECMO? So this is so when we said that it was full bypass of the lungs and the heart, that's the advantage of VA ECMO, is that you get to fully support the patient in all ways, heart and lungs. And because you're fully supporting them, there shouldn't be mixing of the arterial and the venous side. But what I mean by that is in a way that negatively impacts you. Because we already talked about how, yes, you can have mixing of arterialized blood in the sense of pulmonary venous blood coming into your circuit, but in that case, you're doing it intentionally. And so what's being delivered to the patient, everything that you're delivering to the patient is what the patient is getting. There's no recirculation, nothing going back into the circuit and feeding back on itself. And then because of that and not having any recirculation, so everything that the circuit is doing is highly efficient setup, so it means that you get the most amount of oxygenation for the lowest amount of flows on the circuit. And again, going back to thinking about the circuit, the lower flows you have to have, the lower RPMs you have to have, also the better oxygenation you have, the lower hematocrit you need to have. And so in all of those cases, you have lower hemolysis rates when you're on VA ECMO than when you're on VP ECMO. Jose did it for you. He's a genius. I could never.
Just a red
It's really
button.
hot in here.
Is that why I'm not shaking? I'm
Yeah.
comfortable?
Yeah, it's comfortable in here.
And so because you get the maximum amount of oxygenation, you get the best chance at doing what we talked about, which is turning down your ventilator and giving your lungs a break while you're on ECMO. So if those are all the advantages, it sounds pretty good, right? Because now you're putting your patient on and you get to do everything you want to do for them. Do you imagine that that's free? No. So what are the disadvantages of being on VA ECMO?
Carotid ligation.
So carotid ligation if you're doing a med cannulation. What else? What did you guys tell me about or ask me about on the break?
Non-pulsatile flow.
So non-pulsatile flow, you have continuous flow, and there's debate about how happy the organs are with having non-pulsatile flow. What else?
If you're running out low flows, then you're going to run into thrombus issues,
But
coagulation issues.
is that any different in VA versus VV? No. And you have to run pretty low flows in order to have thrombus just from your low flow state. So where
two
you-
sites, you have two sites of infection, like two sites of entry into the body and two sites of
Yeah, you
potential
could.
infection, vessel damage.
Yeah, you could, and but that gets into the issue around the carotid that Kent was talking about. But you can certainly have an issue with your aorta. The other real thing for me when I think about VA, and this is to me the real reason why I think a lot of times about getting by with VV instead of VA, is when we talk about VA, what does the A mean? Arterial. So where are you giving blood right? So you're giving blood back to the arterial side of the body directly. And so we've been talking about thrombus within here. And so the big disadvantage of VA ECMO is that you have a serious risk of systemic embolic phenomenon. And if that means you shower your kidneys with thrombus and you get AKI, who cares? Because you can put them on dialysis while they're on the ECMO circuit, and patients can be dialyzed afterward, and there's so much redundancy within the kidney. Most of our kids come back. It's not like adults, right? The real issue is if you send that embolic phenomenon to the brain. The other one that people talk about is this question about whether it's suboptimal. What is written here is the suboptimal conditions for the LV. And there is debate about what myocardial stun is and how much of artifact it is of the ECMO circuit actually being bad for the LV in and of itself. So when people talk about myocardial stun, first of all, to me, all that is a name for is cardiac dysfunction. So I don't like creating new names for things because then it makes me think that it's a whole different disease process. So myocardial stun says that you have cardiac dysfunction. Now, some of the myocardial stun that occurs is when you actually cannulate patients to VA ECMO. I was going to talk about this tomorrow, but we might as well talk about it right now. So when you have this patient on a VA ECMO circuit, so we were talking this morning about how if that's a neonatal circuit, that's 250 cc's of volume, and you have a 3 kilo neonate. So if you have their circulating blood volume outside of them, do you suppose that that is all just prime with saline? No, right? And so now when you think about myocardial stun, you got to think about what your cardiac dysfunction when you're cannulating someone to ECMO, it all has to do with what they're being exposed to from that circuit. So what you need to know is what your circuit is being primed with. So just because they're being, even if this was saline primed, all the plasticizers that are within that create an inflammatory response in the body itself, and so you can see decreased function just because of that. But in addition, these circuits are primed with blood, and so it takes at least a unit of cells to prime the circuit. So if there are PRBCs in that circuit, what do you suppose happens as a consequence of having PRBCs in that circuit?
Yeah, the hypocalcemia with the citrate.
Right. So number one, PRBCs would clot if they weren't anticoagulated in some way. And so the way that our blood products are anticoagulated is with citrate, and citrate binds calcium. So if you just expose the patient to their whole circulating blood volume of citrate, then you can make them profoundly hypocalcemic, and that can profoundly decrease your cardiac function. So one thing that we do when we prime these then is that since there are PRBCs in there, and you want to get rid of that effect, because not always are you cannulating someone to cardiac support also, our recipe for priming includes calcium in it. So if you're reversing the calcium effect or the citrate effect of the PRBCs with calcium, what else do you suppose has to go into the prime recipe? Yes, heparin. You guys don't have to whisper. I ask questions even if they're not rocket science just to make you feel good. So, right, so the circuit is also primed with some amount of heparin. It's not enough heparin to anticoagulate your patient fully, but it's enough heparin to keep the circuit from clotting once they add the calcium to it. Okay, so PRBCs have citrate in them, which makes you hypocalcemic. What else do PRBCs have in them? Potassium, right? So because the red blood cells are breaking down, and you're lysing and sending that potassium out. So you could have a hyperkalemic circuit. When we cannulate here, what we try and do is we'll order washed red blood cells to prime the circuit. It takes 1 hour to wash a unit of PRBCs. So depending on how urgently you're cannulating to someone to ECMO, you may or may not be able to get your washed cells. But washing it really does take in a significant amount of the potassium out of the circuit. If you don't have enough time to wait for your PRBCs to be washed, do you guys suppose you're cannulating them to VV ECMO? No, probably you're rushing things along and you're going to put them on cardiac support anyway. And then besides potassium, what else is different about PRBCs than our circulating blood?
230
Yeah, you can, that'll change some of the way you have your oxygen dissociation. The other thing that I'm getting at is that PRBCs also tend to be relatively acidotic. And so in addition to the calcium and heparin being added to the circuit, the other thing that they add is bicarb. And also it's deoxygenated and has CO2, so before they go on, once they prime the circuit, they'll run it through the oxygenator a few times to blow the CO2 down and then add the bicarb to it. So if I tell you that without adding all those things to it, that you're about to connect your patient to something that's going to expose them to a hypocalcemic, hyperkalemic environment that's acidotic, does that sound like anything else that we sometimes do to patients? Sound like cardioplegia when you're operating in the OR. So that's the cardiac dysfunction that you see when you first put a patient on ECMO most of the time, is that you're seeing those electrolyte shifts and acid-base status. So when we talk in cannulation tomorrow about one of the parts of cannulation, it's to get a blood gas off of your circuit before you go on. If you're going on VA, it matters less, right? Because you're fully supporting the heart, so that if you cardioplegia the heart, because because your ECMO circuit is gonna take over for you right away. But if you're putting someone on VV, the pediatric surgeons would greatly appreciate if you did not cannulate the patient when they were just trying to do a VV cannulation. And it really can make a significant difference. And for you guys, this is one of the places where thinking about how ECMO relates to CVVH is good. Because when you're watching your patients get cannulated to VA, even knowing that we reverse a lot of those things and you look at your blood gas and you realize it's not that bad, watch what happens on their art line when they're cannulated to ECMO. Everybody will dampen their dampen their A line some, even if they don't fully flatline it. So that's the same thing that's happening when you're putting somebody on CVVH. It's just that when you're putting them on CVVH, it's a much smaller volume and it's not necessarily blood primed. Although in the NICU, you guys are starting to think about blood priming, and I'm actually going to advocate in the cardiac ICU that we change our strategy around that. But so you are doing a similar thing with CVVH. It's just that you're usually doing it in patients who only have a respiratory problem, and so they have decent cardiac function, so they're able to recover from that. But if you have somebody that's already sick, and then you relatively cardiolegish them, you really see a significant decline in their cardiac function as you go on. Good. So then in addition to the fact that you do that to them initially, this whole suboptimal conditions for the LV is then what happens over time, and then that's where there's this debate about if you have a cannula in the aorta that's increasing the resistance to the LV. Number one, is it positioned in the correct direction so that you're getting good retrograde flow to the coronaries if the heart is really that sick when you're first going on, or the lungs are really that sick when you're first going on. And then number two, is there enough capacity for the blood flow to get around the cannula? So I would say the vast majority of the time the answer to that question must be yes. Otherwise, we would never get patients in the cardiac ICU who couldn't separate from bypassing the OR to ultimately be able to separate, and yet we're able to do that 60 or 65% of the time. So we can do it more often than that, but that's our survival rate. So I think that that plays less of a role, but it is one of the debates that people have. Okay, so moving on from advantages and disadvantages, this goes back to what Rachel was talking about in terms of gas exchange, and then what I say when I talk about ECMO, which is about cardiac output. So the amount of flow that you have going through your ECMO circuit is directly proportional to the amount of support that you're giving your patient. It's a linear relationship. You turn up your flows, you have more cardiac output. You turn up your flows, you have more oxygenation until you hit the limits of your oxygenator.
If you're increasing the flow to improve your cardiac output or your mean arterial pressure, do you decrease the sweep flow to compensate for the increase of PaO2, or are you just like, all right, they have a PaO2 of 200-300 now, that's great?
Well, does sweep affect your PaO2?
No.
Right, so sweep is ventilation, number one, and CO2 diffuses so
I guess it'd be
rapidly
I'm sorry.
that your blood flow does not affect ventilation whatsoever. So there's that. And then in terms of oxygen delivery to the body, no, because yes, you have a PaO2 of 200, but this is why most people don't worry about that. The thought with oxygen toxicity in the lungs is that you're directly inhaling the oxygen, and that's what's causing the free radicals within the alveoli that's causing all the damage to the parenchyma, more so than that you just have a high circulating PaO2 out in the body that's causing the oxygen free radicals. So nobody cares if you've got PaO2s when you're on ECMO of 250. Good question. Okay, so now VV. So what's VV ECMO? So we talked about actually all these slides I think are similar to the slides we talked about. So there's a picture of a neck cannulation. So this is the origin cannula, and you can see that it's well labeled, going back to the question about positioning of this, that here's your inflow, here's your outflow, and you can see that it's positioned so that the inflow is medial and not lateral, so it's pointed at the tricuspid valve. And that was the picture that I thought I had uploaded to that other presentation, just for people who don't have good visual spatial skills like I do. I have a hard time upending that cannula, so this is what it actually looks like. It's in the heart, so blue blood going in here and red blood going here and through the tricuspid valve into what is apparently a hypoplastic right ventricle. Okay, so what do you get from VV then compared to VA? So what you get is you get partial bypass, and when we say partial bypass, the only thing that you're bypassing is the lungs, right? And you're not even bypassing the lungs. What you're doing is you're just taking blue blood out before it can get to the lungs and oxygenating it and then giving it back in, and then the right heart still has to be able to handle it to put it through the lungs. The lungs have to have low enough resistance within them to allow the passive blood flow through, and then the LV has to be functioning well enough to take it over. So it really is just partial bypass. It's hard for me to even conceptualize it as bypass or think about it in those words, because when I do, I start to think that the lungs are out of the equation, and the lungs are not out of the equation. It's just that you're not relying on them to function as your gas exchange. So then, if what you get is this partial bypass, or if you get it just doing the job of the lungs, what are the criteria for going on VV? So the criteria for going on VV then must only relate to the functioning of the lungs. So you have primarily hypoxic respiratory failure, like it's just the same as with VA, very rarely are you going on for hypercarbia. And then the question is what do you do with patients with pulmonary hypertension? And this is forever the debate when you have a patient who has profound respiratory failure and is on some inotropes, is can you go on VV or do you have to go on VA? And it really depends on what you think is the disease process that your patient is having. Because if you have a patient who has a respiratory disease process and has pulmonary hypertension in the context of that, and you haven't been able to improve their oxygenation or improve their pH. So what are the things that drop pulmonary vascular resistance? So oxygen and alkalosis. So one of the thoughts is that if you have somebody who has respiratory failure and some degree of pulmonary hypertension with RV dysfunction in the face of that, what if you instantly are able to take their blood and instantly make it oxygenated and instantly make it alkalotic, and will the pulmonary vasculature be reactive enough that relatively quickly it will start to drop its PVR, and then the RV will become happier, and then you can have a VV cannulation. So this is truly the crux and heart of the debate that oftentimes occur at the bedside. The other part of the debate that can occur in the NICU is just comes down to cannula size. So is the kid of a size that you could actually put VV cannulas in, or are you rate limited by the amount of flows that you're going to get in order to have to put them on VA? But the vast majority of the time, the debate that occurs has to do with whether you believe that you have reversible RV dysfunction because you have reversible pulmonary hypertension.
Along the same lines, I didn't understand this, but when I was reading on this, they talk about some who have cardiac dysfunction, and they talk about hypoxic cardiac dysfunction. So if VV ECMO can be beneficial for these people rather than putting them on VA ECMO. But how would you tell the difference of somebody like a meconium aspiration that's, that they're not going to need the VA ECMO, or you just take the chance?
I have never had a patient that we put on for primary cardiac reasons that also happen to be hypoxic that we ever debated VV, and maybe their cardiac function will get better if we make their oxygenation better. It's pretty, I can't imagine that, because I'm trying to think of all the different kinds of cardiac failure that I've seen, and all of them are so primary to the heart itself and don't have, I can't think of it, because it's not like, none of them were hypoxic to begin with. They can have coronary ischemia for a variety of reasons. So a transposition that has an arterial switch and they move the coronary buttons and they have impeded coronary blood flow and have myocardial ischemia from that. If you can't transition off of bypass in that moment in time, they're already being supported on bypass, so they're already oxygenated. So I can't think of the case where that would be true outside of pulmonary hypertension in the pediatric environment. I can't even think of the adult environment right now, but I feel very confident in the pediatric environment that I can't think of the disease process that would be true for. So then the exclusion criteria for VV is obvious, is that the exclusion criteria all has to do with whether you believe that you have cardiac function or not. And so if you have signs of impaired cardiac function outside of isolated RV dysfunction, then you are not a candidate for VV. And then like we were talking about earlier, if you're actively doing CPR on a patient, so you can't wait for your washed red blood cells to come back, even if you instantly oxygenate those patients. Anybody here willing to bank on them all of a sudden having a functional heart? So you can see that the way we wrote those does not have specific exclusions in there, like if you're on dopamine of 15, then you don't get to have VV, because it doesn't matter how much inotrope you're on. What matters is whether you believe that you have a reversible process, a rapidly reversible process. So the advantages of VV ECMO then are, so they're all the disadvantages of VA ECMO. So you don't have to sacrifice the carotid artery, so you can feel good about your cerebral perfusion. You still get to have normal pulsatile blood flow. And now when you are cannulated, your cannula is going into the right atrium, draining the right atrium, and feeding the right atrium. And so your lungs still get to act as the filter that they always have. So unless your patient has an ASD or a VSD, you have no risk of systemic embolization. Yes, you can have a PE, but you can't have a stroke. And then this whole idea around the LV, that you're not stressing it because you don't have a cannula in the aortic arch. So the disadvantages of VV ECMO, you need a functioning LV, but really the disadvantages of VV ECMO all are about this concept of recirculation. And then that you may need to convert to VA ECMO. And technically, the outcomes of VV ECMO are better than the outcomes of VA ECMO, but it's really hard to separate those two out for me, because if you're so sick that you need VA ECMO, I'm not sure you're the same patient as who needs VV ECMO. So is it really that VV is better, or is it that the patients aren't as sick? And then the outcomes of patients that were cannulated to VV and had to be converted to VA are worse than the patients who were just on VV ever. But again, is that because VA is that much worse than VV, or is it that those patients got sicker and are a different patient category than the other? But that is partly why some people argue about never to do VV. And I would say a lot of the decision-making around VV and whether you believe they have a reversible disease process or not comes down to individual physician preference and institution preference. If you go to different institutions, you'll find that they all kind of tend to do the same thing. So I would say for us on the spectrum here, we tend to be an institution that does less VV ECMO and go more quickly to VA than other institutions. So recirculation. So recirculation, as Rachel was talking about, is that you've got this oxygenated blood coming right back to your circuits. We'll talk about this. So this is that same slide that she showed you this morning, just going over it again. So what you have here is this is your patient's effective flow. So you may be dialing up their flows, but that as this is their recirculation fraction. So that as the recirculation fraction increases, you're going to get less and less absolute blood flow to your patient, right? Does that make sense to everybody? Okay, I see all heads moving, that's good. So what you're looking for when you're on VV ECMO is trying to find this part of the curve where you are maximizing your oxygenation and before you get to the point that you are maximizing your recirculation, and then you can actually get to a point where your patient oxygenation gets worse because of the amount of recirculation that you have. So how do you do that? So, I forgot the schematics were in here. So this just shows you that if you have a patient who is on flows of 200 here, and you have a 20% recirculation fraction, then really they're a little bit above 200. No, they're at 200. What is happening? Oh, they're a little bit above 200, and then you have 20% recirculation, and this is a little bit offset. But really their effective flows will be right around 160, just above the 150 mark, right? Because you're losing 20% of your 200 back to your circuit and not out to your patient. As opposed to as you go up, and now you're flowing at 500 on that patient, and you have 50% recirculation, and so now you only have flows of 250. So you just are buying more and more hemolysis, right? Because you're flowing and having higher and higher RPMs and without any advantage. So there are different things that we can do in order to figure out how much recirculation that we have. So one thing is for people who like formulas, you can actually calculate a recirculation fraction. Right now, there are no, right? We haven't written it yet, Kim, have we, about calculating the recirculation fraction? It's not officially in play yet. So right now, as an institution, we don't require that the ECMO specialists are doing this, but they will be. And those of you in the NICU, when you're in service with Dr. Friedlich or Dr. Chapman, you should remember this formula because you will be. So for this, your recirculation fraction is the difference between your pre-oxygenated sat minus your SVO2 on the circuit, and then the post minus the SVO2, so that you can come up with numbers like 17%. Oops. Versus that math. I'm assuming you guys don't need me to walk you through the math. So the rules of thumb when you're trying to figure out what's happening with your recirculation and how, because really it's one thing to calculate the amount of recirculation, but really the reason why you're doing it is because what you're trying to do is find that sweet spot on the curve and maximize the amount of flow you deliver you're getting to your patient, minimizing the recirculation. So the first concept to remember is that more flow will always mean more recirculation. It just may not make a consequential difference to your patient. But if you don't have that in your head to begin with in VV, then you are at a disadvantage along the way. And then the question is not whether more ECMO flow will increase recirculation. It's whether more ECMO flow will help your patient or not help your patient. That's actually the question you're asking, as opposed to in VA ECMO where we're talking about it being the direct linear relationship. More flow will always help your patient. So the things that relate to recirculation all have to do with the ability for you to have free access of the blue blood to the blue ports and free egress of the red blood from the red port. So you want to have as big of a space as possible. So when you're thinking about that origin cannula, for example, if you have a right atrium that's a small right atrium, when the red blood goes into the right atrium, it's more likely to sit and fill the small space, right? But if you have a nice full right atrium with lots of blood in it already, there's not as much space for it to mix around. So volume status and the position of the cannula really makes a big difference for your patient. So again, your patient who, when you first cannulate them and they're super volume repleted because you've been resuscitating them for a long period of time, will have one recirculation fraction. That patient 3 days later, when you're actively diuresing them and they're becoming intravascularly hypovolemic, may have a very different recirculation fraction, and you may have trouble then with your circuit. And then it becomes this debate about how hard can you diurese them to improve their pulmonary function versus you can't diurese them as hard as you want to because you're increasing your recirculation too much. And then you can also just have subtle changes happen, again, especially in the little kids, as you have that kid, if you remember the x-ray, the head was all the way over to the side. If you take that head and you start repositioning it because you want to minimize the risk of them developing pressure sores while they're hospitalized, are you doing subtle shifts to your cannula that may impact your recirculation? And then ECMO flow, and then RV contractility, because if your RV is not functioning very well, then that forward red blood that's going into the right atrium isn't going to move into the RV and out the RV to the lungs. It's just going to stay within the right atrium because it's pressurized, because the downstream system is pressurized. So,
I know this is like a controversial, but just like you were saying, we tend to be more on the VA spectrum. Like you were talking about lung volumes, so rest settings here, the last kid I saw on ECMO, and I think you here had like a peak of like 18. So I'm assuming you guys don't do rest bed settings in the stereotypical. Maybe that was an exception.
No, I'm laughing because I know when attending was on when you tell me. But
and I remember seeing it and being like,
yeah. That's probably
that
why I
was
was
just
laughing too, is because I remember the first time I was on call and I went into the PICU and they told me the patient was on a peak of 18. I was like, excuse me?
But I know that that's like an institutional thing here where peeps are,
Right, but so for me, the way that I think about rest settings is that when you go back and you look at the ARDS-NETS trials, the things that we think are associated with barotrauma and problems for lungs down the line relate to either you believe it's tidal volume, or it's PIP, or it's delta P, or some combination of all of those things. It's not really about the mean airway pressure. And your idea is if you've got good mean airway pressure and you have good lung recruitment, then your lungs should be at the best point on the compliance curve. So I think that when we think about rest settings, it's about what mean airway pressure do you need to maintain to try and keep your lungs recruited as much as you can. And then usually, for me, the rest settings come more into play about either running a low tidal volume or a low delta P or a low PIP, and then also a low rate. So it's not uncommon that these kids, as opposed to being even our neonates in the cardiac ICU, for example, where you would expect them to have rates on the ventilator set in the 20s with an I time around 0.5 seconds. Those kids commonly, or as a rule, will start off with a rate of 10 and a 1 second I time, and then some peak between 6 and 10, depending on what RT is on, that says this is what we always do, which we're going to fix also. And so that's really where the debate happens. I think the other reason, so it's a little, so I would say it's not surprising to me that there was high PEEP. The question around the rest of it, though, becomes a little bit of attending preference and then the team style as well. So I think that in the PICU, I can't comment in the NICU, but I will say in the PICU that I think they have great difficulty when kids get cannulated to respiratory ECMO with the RTs not getting and the rest of the team not getting that the ventilator is no longer important, or hopefully is no longer important. And so I have come in when they've cannulated kids and then come back in the next day and realize that when the patient was desaturating overnight, they were going up on the FiO2 on the ventilator, up on the settings on the ventilator, and forgetting that they were on ECMO. And so that's why I try and drive home to you guys this concept of that there are significant downsides to being on ECMO, and once you've bought all of those downsides, you might as well maximize your ECMO circuit so that then you can minimize those other things. But it does require a major mental shift, because when someone hands you a blood gas that's 73065, it's so hard to change your reflex and say, oh, did you go up in the tidal volume, or did you go up on the rate, or did you go up on the delta P, whatever you would normally say. And then depending on the units and how autonomous the RTs are, a lot of that may happen in the background without you being aware.